So I am an alumni of this department. I did my master's 20 years ago. I graduated, um, and it was in evidence-based social work. So I was the second year of the evidence-based social work MSc. And since then, they've changed the name and all sorts of things have changed. But it's really lovely to be back here because the lovely thing about Oxford is not many things changed. The department was still here. The rooms are pretty much the same. So it feels like I'm going back in time and feels a bit odd now to be the person that's up here lecturing. But it's also a really nice thing to be able to come back and meet all of you and I think take stock a little bit about how my life has changed in those 20 years. But for now, I'll be talking about how my life has changed in the last 5 years since I started this project. So this project was or is the project from my Future Leaders Fellowship, which was really about, why is it, my kind of preface is, why is it that in global mental health, we have so many evidence-based interventions, but we actually don't see any, or very many of them at all happening in real life? So this was a big question for me, and I sat down and thought about it for a while. And kind of my main kind of conclusion was that a major contributor to that was just the way in which we traditionally develop interventions, and the fact that they don't necessarily align with or make sense to the people who, in the end, have to either deliver that intervention or are going to receive, or the gatekeeper for the recipients of that intervention. So I started thinking about that. My kind of general area of research anyway was in child and adolescent mental health. And so if I was thinking about my area in public mental health and mental health promotion for young people, a lot of the interventions that we're thinking about were developed in high-income countries, and they're primarily based in educational settings. But when we move into low and middle-income countries, oftentimes those young people are not in school, or if they are, not necessarily the most vulnerable people. So in thinking about that, I started thinking about different populations, and the population, I think it's a bit serendipitous of how things came together, but there were calls then specifically about teenage pregnancy and mental health. And I kind of went with that because I said, okay, that's a really vulnerable group. They're a hard to reach group. So how can I kind of work with this? Okay, so why am I really interested in teenage pregnancy and mental health? Well, for me, we know that across the lifespan, that adolescence and young adulthood, really that area is very vital to mental health across the lifespan. So we know that that's a particularly vulnerable time. We also know that for childbearing people, pregnancy and this kind of shift into parenthood is also a really important time and a risk factor for mental health issues. So it's no surprise that when those two things intersect, that you have a heightened risk. So there are estimates that 1 in 3 and up to 1 in 2 adolescents will experience a mental health condition either during pregnancy or in this year after birth. And then if we're thinking about where teenage pregnancy is most prevalent, it is primarily around sub-Saharan Africa. I mean, it's prevalent in other places as well, but many of the countries in sub-Saharan Africa see very heightened rates. So Mozambique and Kenya is where I'm working, and Mozambique, at the time, I don't think it's changed that much, but they had the 4th highest prevalence of adolescent pregnancy. In Kenya, although they have a lower prevalence rate in comparison, the sheer numbers of young people and young girls means that their absolute number of pregnancies is 10th highest globally. So these are two countries in which there's a definitive need for support. At the time when we started this and I was writing the application for the fellowship, that was 2018, 2019, there were no interventions specifically for teenage pregnancy for mental health that were evaluated in sub-Saharan Africa. So, thankfully, around the same time, I kind of got this idea. Other people have also gotten the same idea. And there are some other projects that have been running in Sierra Leone and in Malawi doing similar things. And the nice thing is that we've kind of come up with very similar results and findings and interventions, which is nice and points helps to kind of point to the potential for generalizability. The other thing that people always told me when I was starting out in this was like, why do we care? We've been working really hard at reducing teenage pregnancy, and the prevalence rates are going down globally. So why is this an issue? Why should we invest money in this? And I think that there's, I take a lot of issue with this because there still are quite a lot of pregnancies that happen. And in Africa, because of the demographics of the population, despite a lower prevalence rate, just like in Kenya, the sheer numbers means that there's actually anticipated to be a rise in the numbers of pregnancies moving forward. So it's still a highly salient topic. And I think because of this global push to reduce teenage pregnancies, what has happened as a result is when a girl becomes pregnant, people kind of wash their hands of her. They say, well, we did all of this stuff to try to stop you from becoming pregnant. You got pregnant anyway, and so now this is your fault. When in actual fact, from a lot of the work that we do with these girls, and you find out the situations in which they are becoming pregnant, you realize that actually, for most of them, this is not at all what was planned. They either had very little education or no opportunity to actually prevent this pregnancy. So, it's something that I hold very close to my heart, and I think is still a really salient issue, not only for the girl, but also for the offspring and the development in many of these countries. Okay, so I talked about, this traditional way about developing interventions. I like to think of it with kind of this analogy that we've got this kind of messy problem. And I think about it as either tangled fishing wire or a ball of yarn. I like to knit, so that kind of makes sense to me. But you just imagine that it's kind of a mess. You have no idea where the start is. You have no idea where the end is. And our job is to unpick it. So how do we unpick it? We start to pull together all these things that we do know. So are there any theories or frameworks that we can try to understand this with? What is the existing evidence? Are there any guidelines or recommendations? And then also, we talk to experts. And in this kind of traditional way, who would you kind of think of as the people that we would talk to be deemed as experts? So kind of those high level people are the people we kind of, well, I'm part of that as well, but the people who we kind of say, oh, you know everything, so you just tell us, what you're supposed to do. So if, and this is a strong if because it doesn't happen most of the time, but if we are very, very lucky, we are able to find the ends of those things, we're able to unravel it and then put it back together and find this solution. Now, the issue with the solution, like I said before, is that we have these solutions for mental health issues, but we actually don't see them happening in everyday life. When people say, oh, look, this works, people are not coming to us going, oh, great, tell us how to do it, let's do it now. And part of that issue is that when we look at that yarn, it depends on what you're seeing. So you can be looking at one way and there's a square, but if you look at from the other side, it's a circle. So you imagine that if I asked you to be on different sides of this, and I told you in groups, please come up with a plug to fill this shape. And we've got one side that's got a cube and the other side that's got a sphere. And now they're looking at each other going, what are you, how, like, why? So that's very much kind of the way, I see as the problems that we have is that we are coming into this from our own perspectives. We're seeing what a problem is from our side, but not necessarily the other problems that are important to other people. So if we're not including those people in the room, we don't know. We have a blind spot. We have no idea what they're thinking and what they need and what their motivations are. And so we're coming up with a solution saying this works, and they're going, that doesn't do anything for this problem. The real problem is this. And so they're less motivated or not motivated at all to actually do anything about that problem or deliver your intervention. So really what we need to do is kind of shift this traditional way of looking at things, and our experts become much more wide-ranging. We need to get people in who we expect to fund these interventions. So we need, at Ministry of Health level or Ministry of Education or wherever you're working within governments, we need to have the funders of research projects. We need to have the frontline providers. We need to have the individuals that would receive that intervention and any gatekeepers. And ideally, also other people in the room that have different expertise that might see things or see solutions and connections that we might not see. So I'm always saying, like, I'm always happy to talk about my project with anyone and everyone. Usually, even if I'm talking to somebody who doesn't really know much about mental health, and I kind of just tell them these are the components or these are the types of things we're doing, they'll go, oh, I'm working on something else, or I know about this, and there's something that overlaps. So it might be a method, it might be kind of a challenge that is more generalizable that I can then learn from and think about and say, okay, could this be something that will help us? And is there a simple answer to this? Because when we're developing interventions, we want the simplest intervention or solution possible, because that will have the best chance of actually becoming embedded within the system. So with that kind of in mind, we started the Inspire project. So what we started out with was kind of this question about how might we improve the mental health of girls during pregnancy and the year after birth. So really general. We had some ideas from our own research, but then we wanted to include different people in that. It's a collaboration between ourselves at King's and the Center for Global Mental Health, but the Aga Khan University based in Nairobi and the field office in Mombasa, because we're working in Kilifi, which is a county nearby. And then with the International Center for Reproductive Health Mozambique, which is an NGO based in Mozambique that does a lot of research, but also programmatic work. So it's quite interesting then having academic side and an NGO side working together. I think it strengthened our capabilities and our understandings in doing that. And as a result, we have some good expertise and some different ways of engaging with the communities. And then we also partnered with the Royal College of Art at the Helen Hamlin Center for Design. And that was around these ideas around co-production and human-centered design. So the project ran for 4 years. So the initial part of my fellowship, which ended in August of 2024, so just over a year ago. And it had 2 different phases. So we had first this phase around intervention development, which was where we really worked with the community to understand what their motivations were, what they believed, what they thought their responsibilities were as different stakeholder groups to providing and supporting adolescent mental health in this context. And then also bringing in what we knew in terms of the evidence. And there we find kind of in the middle where all those things intersect are kind of what possible solutions there are. So once we then did that, we moved on to pilot testing, which lasted for probably about 18 months. And in that, it was all about, just understanding how this works. Could it work? Was it feasible? Was it acceptable? Was it appropriate to the delivery agents, to the girls, to their families? So just a little bit of kind of more detail. And I realize that these screens aren't that large, but don't worry about what's inside. I'll kind of go through it. We have kind of the human-centered design aspect, but also layered on that, really thinking about implementation science and systems thinking. Because really, we're not developing this intervention, or it's not going to be successful if we only think about the intervention on its own. We have to think about how it's going to fit, how it will be delivered, who's going to fund it, how do these things work? 1, to identify who the stakeholders we need to engage are, and 2, to just make sure that we are not at a point at the end when we say we've got this intervention, we go, okay, how do we shoehorn this in? And in doing that, we also get the buy-in of all of these different stakeholders who see this project and see this intervention as theirs, and then they have every kind of reason to try to make it a success. And we really found that over the 4 years that we've been engaging with this community. So we started out first with just trying to understand what was going on. So in human-centered design speak, this is kind of the empathize phase. So we had scoping reviews, we had stakeholder interviews, we observed, we did observations using photo voice. So they were non-obtrusive and the girls could kind of really show us what their lives were like. And then we did service mapping, which was a series of oh gosh, I can't now, I'm forgetting, spiral walks, that's what they're called, in the communities, finding out, where are girls spending their time? Where are places that they would like to go to, but they feel like they're not really allowed to be there? Where are places that they would never go to and why? And so that allowed us to understand, where they sat in this community and also to identify potential places to actually embed the intervention. Then after that, we kind of pulled together and triangulated what we had learned from all of those different stages and brought that back to the stakeholder groups and said, okay, here are the kind of main things that we saw as challenges. Let's decide together as what our priorities are. What are we working together towards? So once we're able to do that, that helps to kind of get all of the other noise out. Because then if you have a stakeholder group who's advocating for something that is on their wish list that doesn't necessarily fit, we can say, well, that's great, we're going to park that, but it doesn't really fit what we've all agreed as to kind of what we're working towards. And that just is also a way of just getting everybody to be on the same page and to reduce some of the frictions or the tensions or advocacy efforts of different stakeholders to mold an intervention to what they want and not necessarily what other people think is important. So once we do that, then we can start to come up with these ideas. So we come to the ideate stage where everybody just throws out any ideas they have. They can be crazy ideas that would take too much resource and is never going to happen, but there might be something in that we say, okay, we can actually tweak this and adapt it for something that could be provided, or really simple, small ideas. So it might be something that somebody did or that happened for a girl or her family that worked really well. And then we could think about, well, could this work for others? So really coming up with those ideas and getting the group to identify, well, what could work and what couldn't. And then once we had some, one or two ideas that we thought these are the things that we want to move forward with, then it's all about prototyping. And I think for me, there's a lot of alignment with just kind of traditional intervention development and the traditional research process. For me, the prototyping is what sold me on this method in particular. And the reason why is because we don't go straight into a pilot study. We then show people what it's like. We show them, here's some of the materials. This is what the content looks like. What do you like? What don't you like? This is who's going to deliver it. This is how it's going to work. And so then they can say, I'm not sure that's going to work, or maybe we should try it this way, or that's great. And I would definitely do that. Because if you start and just ask people what they want, they don't know. I mean, it's for anything. You ask somebody, what is your ideal? It's really hard to say, but it's much easier for people to say the things that they don't want. And also to then look at an example and go, I like this and I don't like that. So being able to show people that first before you go to your pilot helps to pull out these things that would just be fairly obvious and cause your pilot to fail. So that the idea is then you go into your pilot with an intervention that has the best chance of actually having a good impact and getting the results that we want. So it takes some time, but it also reduces, the amount of money that's spent on things that probably shouldn't have been piloted at that stage anyway. So over those kind of 4 years, we partnered with now it's kind of over 200 different stakeholders since October of 2021. The vast majority of those were adolescent girls or young women who experienced a teenage pregnancy and could talk to us about what happened to them afterwards, what things helped and what they wished they would have had. Their partners and family members about what they thought the challenges were, what challenges they had themselves, and also what responsibilities they felt they had to this girl, to the baby, in order to create this kind of fostering and nurturing environment. Then talking to service providers in health facilities, but also out in the community. So maybe community-based organizations that are providing services, and also then community leaders. We called them community influencers. So anyone we thought could either make or break the project. So it might be, the leader of that community. It might be a group of older people. It might be a pharmacist. It might be a head teacher. It might be a religious leader. So anyone who might then go, oh, I don't think this is a good idea, or I'm not sure about this, and other people would listen and maybe distance themselves from it, we wanted them involved. We wanted them to have buy-in so that they would go, oh, I'm part of this though, and so it's in my best interest for this to succeed. So what did we come up with the priorities? When we started this, we did this separately in Mozambique and Kenya. We didn't do them together. And that was on purpose because I didn't want to make a singular intervention if that wasn't appropriate. So we did those things separately and then came together from the different teams to see what was coming out. And I think luckily, very much there was a lot of overlap. So of course there were contextual differences and priorities based on different settings, but overall there was a clear message about what was important. And I guess looking at this list of things, they're not surprising. And probably if you went anywhere else in the world where you found an adolescent who became pregnant, these would also be things that they would find difficult, as a challenge to their mental health. So again, that helps us to feel a lot better about one, developing a singular intervention and its potential to have reach not just in these communities, but within the countries as a whole and kind of more widely. So through all of this, we then kind of worked with people to say, okay, what is this going to be? What do we want to do? I think one of the things about human-centered design is people think, oh, because this is like a new or potentially new, although I don't think it's very new, but because it's fairly new in the field, it's innovative. And so there must be some crazy intervention that comes out of it. But actually, like I said, simple is better. And what is the thing that works? So what we came out with was what we call the Thriving Mamas program. So it has different names in Mozambique and Kenya. So it uses the local names. And the girls actually came up with what name they wanted to call it. But in English, this is what we call it. It is an enhanced antenatal course. So nothing crazy about it. Because what it was is a lot of the things that the girls needed was this reassurance and information so that they felt like they knew what was happening, they knew what to expect, and they felt competent in dealing with whatever was new, these new situations that they were being put in. So overall, it's group sessions. Girls are put into a group of 10. And in that group, they learn about how they care for themselves and their babies. So these might be things about what gestational stage you're in and what does your baby look like now? What are the things that you might be experiencing in terms of symptoms of your pregnancy? What happens when you go to the clinic? So what to expect at these antenatal appointments. And that was a big thing for a lot of the girls because they had no idea. They're just told you have to do these things. You have a midwife or a nurse that's saying you must do this, you must do that, but they don't explain why. And what we found in Mozambique only through this project was that the girls were being given supplements to take for their well-being and that of the baby, and they were not taking them. They were throwing them out. And the reason why they were throwing them out is because they thought they were abortion pills. Because, the idea is why we want to get rid of these pregnancies. So they just thought, oh, this is what they're doing, so we're not taking them, which was not great for them. So it was lovely that this project was able to identify that this was a phenomenon that was happening, not just with one or two of the girls, but almost all of them. And that the mentor mother who was delivering the intervention could actually intervene and explain this is what they were for. And then the girl said, oh, okay. And they started taking the supplements. So, these little things that we might not know about and are expecting, but, came out of this project. Then within that, there were one-to-one sessions where girls could talk about things that they didn't want to talk about in the group. And also mental health screening could happen and referrals to either health or community-based support. So it might be kind of information about how to go back to school. It might be a referral for mental health care. It might be, a pregnancy symptom that they're experiencing that the mentor mother says, oh, you should probably have that checked out. It can be sorted, but you need to go to the clinic for that. So just helping them to feel like, okay, I understand what's happening and this is where I need to go for support. And then when we talked to the families, they said, well, don't just do things for them. We want to be part of this too. And we said, great. So you come to sessions as well. So girls were allowed to identify a trusted family member or friend to attend 2 of the sessions. And in those sessions, they kind of talked about what their goals were for the babies so that they could kind of bond over that. And they learned important skills like problem solving and building positive relationships. So this was all delivered by a mentor mother. And this is where kind of contextually this changed. In Kenya, it was a community health worker who was also, had caregiving experience and could provide that intervention. In Mozambique, it was women that were identified in the community as being respected and people that would be listened to. And that also in Mozambique included a young mother who was one of the girls that was part of the formative work. And what made that a little bit different was that the girls reported, how amazing it was to see somebody like them and that was still young in this role of responsibility, being respected in the community, having a job. And they saw that as hope for themselves, that there was a future for them. So that was really nice. The issue with that was that we then found out that probably because of payment structures and everything, that was going to be a very difficult format in which to provide. And so it will probably be in a trial back to community health workers. But something I think for us to feed back to, the governments and the local community so that they can understand that these, if there's a potential for this, this might be a really good way to engage young girls. So the program has 9 meetings kind of in total. So there's a pre-meeting where there's a program introduction with the mentor mother visiting the girl's home and talking to the family. And then they talk about different aspects at the different meetings. We had a whole protocol for what happened if there was a miscarriage or a stillbirth or an early pregnancy, early birth. And a lot of those kind of meant that the girl would have to actually come out of the intervention and still receive an intervention one-to-one with the mentor mother, but without all the baby things. And that's what we thought was kind of the most appropriate thing, because then the girl, would still get support, but she wouldn't have to go into this group and see all these other girls that are pregnant or with their babies and, feel bad. We also made sure that these documents and materials were adapted for the context. So we hired graphic designers in Mozambique and Kenya to create the materials. So there was a little kind of comic book that came along with that explained a lot of the information. We couldn't, here in the UK, we have NCT, which is the antenatal course, and usually you sign up to that based on when you're due to deliver. So you're in a group with people who are having a baby probably around the same month that you are. Here's a lot different because people are coming to the clinic at different gestational ages and points of the pregnancy. And if we had to wait to kind of figure out how to get a group together, it would take too long. So we just said, anyone that's coming in this time period comes into a group until we get 10 and then we start. Now, the challenge with that is what do you do then when you've got somebody who is 5 months pregnant and you've got someone who is 3 months pregnant? Because if you start talking about what happens when you're 3 months pregnant and in your first, that person will go, oh God, I have to sit here through this and it's boring. So what we did to get around that is we created characters throughout the whole of the intervention. So we had 3 characters, 3 girls that represented the 3 gestational stages and the trimesters. And also each of these girls had different characteristics. So one was living with her father and had already, a toddler. There was one that had moved in with her in-laws and her partner, and one that was just living with her partner. And through that also, we could talk about different situations that the girls might find themselves in. It also allowed in the group sessions for us to kind of make it less personal. So we could talk about what was happening there without kind of getting into people having to feel or feeling like they have to divulge kind of personal information. So that was kind of the development of this intervention. I think it was a really lovely project, but I also want you to hear from the researchers themselves. So I'm just going to play a little video for you about how they found human-centered design, because this was all very new for them as well. And for me, we were all kind of trying this out as we went. So I think kind of one of the things of learning about using human-centered design is you can't help but have those principles also permeate into just the way that you work. And so you see that there with the first, with Melon talking about it in the first section of that video, that actually, this really changed also the dynamic between the research teams and how we work together as a collaborative team. And that I think we had one kind of big problem at the very beginning around communication between the teams, where some members of the teams, particularly the teams that were in the field collecting the data and doing those interviews, felt a bit disengaged from what was going on and what the kind of main ideas were for the study. And it took us a little while to kind of figure this out, but once we did, we stopped the data collection activities for 2 weeks. And we had a series of 3 meetings with the whole team coming together. One, to talk about the things that were the problems that they felt were going on. 2, to talk about the things that they thought were working really well and why they enjoyed being on the project. And then 3, for us to then brainstorm, well, how should we move forward with this? And what do we want to do? And we came out of that with kind of a new communication strategy, a new kind of, albeit more meetings between all of us. But actually, it made a huge difference. At the end of that, everybody felt really good because they were part of identifying what should happen next. And then it brought us together. So instead of continuing to create this rift between us, it made us all realize, actually, we all want to do this. And now this is the way that we're all going to agree that we move forward. So there are things about this process, I think, that have really helped to cement that bond and the hard kind of working and the interworking between us. So our teams are constantly talking to each other on the phone, not just about work, but also sharing personal information and photos of families and trips and, concerts that they're performing in and all of these things. And it's helped us to do our research and do our work so much better. And that also kind of has permeated into the relationships with the community. So then going forward, we started pilot testing. So our primary outcomes and what we were looking at for this was just around implementation. Could we actually do this? Could it work? We also then wanted to just test our trial procedures and see, do the measures work? Do our time points make sense? Can we recruit people? And so what we did was we identified mentor mothers, and that was done within the community. So community leaders and health leaders helped us to identify who would be potential mentor mothers. We trained them, and then once they were trained, we recruited the girls, and we split them into an intervention group and a control group. So it was 20 in the intervention group and 20 in the control group in each country. So 80 girls altogether. The intervention was delivered and we collected data at 3 time points. So one at baseline, one in the middle, so around meeting 4, and then at end line, which was 3 months postpartum, which was when the last meeting happened. And that was a 1-to-1 meeting just to kind of check up on the girl and see how things were going. So kind of overall, kind of going to the implementation, everybody felt that this was actually a really useful intervention and they wanted it. They saw that it filled a gap for things that were already there. So, we asked them, are there other programs that you have access to or that you know about that you would rather take part in? And, they said, no. This provides us with something very specific and we really enjoy it. The other thing, I like to put this up just because I know it's not powered for that, but it was really interesting to see that in the intervention group at baseline, we did have girls that had mild or moderate to severe symptoms of depression and anxiety, but at end line, those went away. So they kind of moved into either having mild symptoms or no kind of symptoms at threshold at all. And so that's just like a really nice thing for us to know that we're not hurting anybody. And actually, we believe that actually there's the potential for the impact of this intervention. I've got 2 more slides and then I'll come to you. So then what have we learned? So we learned that the girls and their families and the communities really wanted to be part of this. I mean, they were calling our research team saying, when's the next meeting? When are we getting together? Well, we haven't talked to you in a while. What are you doing? So, they were making us accountable and they really wanted to be part of this. And that spilled over into a high level of community engagement during the pilot. So we had the community members coming to our mentor mothers going, I've got another pregnant teenager here, enroll her. And we're saying, oh, we've already kind of met our recruitment threshold, so we can't, but thanks. So it was really nice. And also that at the end, so in Kenya, the kind of local health authority came to the last session where there was a graduation, they had a cake, and all of this, and talked about, how important this intervention was to the community, and also not just the intervention, but the process in which we followed to deliver this intervention, and how they wanted to see it across the whole of the county, which was really reassuring to us. Now, what we also found was that the facilitators, so this is in this process, the research process, need really high levels of training, particularly to deal with tensions between stakeholders, because there were sessions where we were only dealing with specific stakeholder groups, but we also then brought them all together because they needed to hear from each other and to take each other's perspective. But sometimes that caused a lot of problems. In Kenya, there was a point at which we thought that the service providers were going to walk away because the girls turned on them and said, you're horrible to us. This is why we don't come to the clinic. And then you think we're irresponsible, but it's because you're so mean and you treat us badly. And, they didn't like hearing that, of course. And so we were very lucky that our facilitators were able to diffuse the situation and bring everyone back to the table, but making sure that there's lots of support for that. And also just getting people to make sure that they're willing and able to take the perspectives of other people, really important. I mentioned why we need clear and consistent channels of communication. These things move quickly, and we're developing, and we're not stopping at stages to review transcripts and analyze themes and all of these things. We're writing notes up, kind of coming up with what our main points are, and then kind of moving on. And then the last thing, again, is that co-design can be used within the team as well as well as within the research activities. And I think that there is a really good benefit of the way of creating and fostering an environment where people, regardless of what role they play within the team, feel like they have a responsibility and feel like they can speak up if something is going, not the way that they would hope it would, or if they see something that they don't like, or to acknowledge when things are going really well. So just making sure that we have a lot of trust within our team to be able to do these sorts of things, because really I act as just a facilitator and it's their project. And I constantly tell them that I can't do this. I'm not there on the ground. These are not, they live in those communities. They know, these people. And so really it's important for them to be engaged in part of that. Okay. So that's it for me. We've got a website where we try to put as much information as possible about what it is that we're doing, and to do that in a way that's accessible to non-researchers, non-kind of professionals. And so there's some videos there, and it's also translated into Portuguese and Swahili, or Kiswahili.